One of the most common diet-related adverse outcomes of pregnancy is gestational diabetes mellitus, or GDM. Pregnancy generally is associated with an increased insulin resistance. On average, there is about 60% decrease in insulin sensitivity during gestation. Some women present with elevated blood glucose levels in pregnancy, although no diabetes was diagnosed before pregnancy. This condition is called gestational diabetes or gestational diabetes mellitus. Gestational diabetes affects some 3 to 10% of pregnancies depending on the population studied, and it typically disappears after the baby is born. The prevalence of diabetes during pregnancy has been increasing markedly around the world, and it is closely associated with the increase of obesity and sedentary lifestyle. It is the most common medical complication during pregnancy. Women who are overweight or obese during pregnancy are at a markedly increased risk of developing gestational diabetes. However, even women with a healthy BMI can be affected. Gestational diabetes is caused by an improper insulin response. This is likely due to pregnancy-related factors such as the presence of human placental lactogen that interferes with susceptible insulin receptors. This in turn causes inappropriately elevated blood sugar levels, most commonly developing in the last and the third trimester. Several adverse outcomes are associated with diabetes during pregnancy. The mother has a higher risk of hypertension, preeclampsia, cesarean delivery, and labor complications. The infant is at increased risk of macrosomia, large for gestational age, fetal organomegaly, shoulder dystocia, hypoglycemia, and perinatal morbidity and mortality. In 2008, a very large multinational cohort study with over 25,000 women was performed, which is called the Hyperglycemia and Adverse Pregnancy Outcome Study, or HAPO study. Findings showed that the risk of adverse maternal, fetal, and neonatal outcomes continuously increases proportionally to the degree of maternal hyperglycemia. This risk was present even within ranges that previously were considered normal during pregnancy. Because there was a continuous association between glucose levels and perinatal outcomes, it was not possible to pinpoint an obvious threshold value at which risk increased. There is, however, considerable variation in the diagnosis of GDM around the world. Many organizations have established different criteria for screening, diagnosis, and defining diabetes in pregnancy. Therefore, it seems appropriate that physicians follow the guidelines specifically recommended in their own country.
Gestational diabetes oftentimes does not present with easily recognizable symptoms. Most commonly, it is only detected by screening blood glucose levels during pregnancy. Screening and diagnosis of diabetes during pregnancy is important for two main reasons. One, the management and treatment of hyperglycemia during pregnancy to improve maternal and neonatal outcomes, and the other one, identifies this woman with a higher risk of developing type 2 diabetes later in life. Diagnostic tests detect inappropriately high levels of glucose in blood samples. There are two common screening practices used to detect GDM. The one-step approach is the oral glucose tolerance test, or OGTT. During the OGTT, a fasting plasma glucose level is obtained, followed by administration of a 75-gram glucose load, and plasma glucose levels are evaluated after 1 and 2 hours. GDM diagnosis is made when one glucose value falls at or above the specified glucose threshold. The World Health Organization advocates a universal one-step diagnostic approach after 24 weeks of gestation. There is the two-step approach, or OGCT, oral glucose challenge test. is performed between the 24th and the 28th week of gestation. This is a non-fasting test where 50 grams of glucose is administered and a plasma glucose levels are evaluated after 1 hour. If the screening threshold of 7.8 millimoles per liter is met or exceeded, in a second step, an OGTT is performed. Normally, it's a 100 gram, a 3-hour OGTT. It is important to note that a high level of false negative results, between 10 and 20% depending on the studies, is associated with the OGCT test, as it is a non-fasting test, and therefore GDM may be missed. Once gestational diabetes has been diagnosed, treatment starts with medical nutrition therapy, physical activity, and weight management depending on pre-gestational BMI. Blood glucose self-monitoring should be performed to allow treatment follow-up. Glucose targets for women suffering from GDM should be fasting under 5.3 millimole per liter and either 1 hour postprandial under 7.8 millimole per liter or 2 hour postprandial under 6.7 millimole per liter. Evidence has demonstrated that around 70 to 85% of women with GDM are able to control hyperglycemia with lifestyle modification alone. That is, a dietary plan and appropriate levels of physical activity. When lifestyle management is insufficient for glycemic control, pharmacological treatment may be necessary. Preferred medications during pregnancy to treat GDM are insulin and metformin. Other oral agents should be avoided since there are insufficient data on the safety during pregnancy.
GDM is an important risk factor for the development of type 2 diabetes later in life. Therefore, postpartum follow-up for affected women is recommended. The oral glucose tolerance test is recommended over hemoglobin glycosylate at the 6 and 12-week postpartum visit. Hemoglobin glycosylate may be persistently lowered by the increased red blood cell turnover that is related to pregnancy or blood loss at delivery. Up to 50% of women with GDM later will develop type 2 diabetes. And overall, there's a 7-fold increased risk of developing type 2 diabetes following a pregnancy complicated with GDM. Recent studies have demonstrated that women with a history of GDM who adopted healthy eating patterns and increased physical activity after birth had a significantly reduced risk of developing type 2 diabetes. Therefore, it is really important to offer lifestyle advice to women with a history of GDM. Gestational diabetes is a treatable condition, and women who have adequate control of glucose levels can effectively decrease the adverse outcomes associated with this complication of pregnancy.